presentation and see if I can go quick and help you.
Yeah, I know, right. So that's easy.
But you're USC or?
So I work for the county. I know, yeah. I have three jobs, so they don't fit.
Good afternoon, everyone.
But yeah, I work for the
All right, I think we're going to get started. Feel free if you need to step out and grab some more lunch. The food's out there. We'll leave the door open. We're keeping this door closed so we don't bother other folks who are having meetings. My name is Cheryl Damberg, and I'm a senior policy researcher here at RAND. And I just want to extend, on behalf of the larger RAND team, a very warm welcome. And we're really happy that so many of you were able to show up today and participate in what looks to be a very interesting conversation about how to improve care for patients with heart failure. The RightCare initiative has been really at the forefront of helping advance practice change in the state of California. Through sharing of best practices, and I want to commend Hattie for her and her team's efforts in this regard. I'm trying to remember who said it. It takes a village. Was that Hillary or somebody else? I know I've lost the trail. But anyway, I think what we've realized working both in California as well as nationally, I know I have been working very actively with many stakeholders in California since I moved to the state. I was at the Pacific Business Group on Health for 10 years, and since coming back to RAND, I've had some involvement with this initiative as well as other initiatives statewide that are looking to improve health care as well as health of the population through programs such as the Integrated Healthcare Association's Pay for Performance program and the CQC initiative that has been run out of PDGH, working with Bruce Spurlock around hospital quality improvement efforts and so on. So I think in California we have a lot to be proud of, but I think we all recognize our work is not done, and that people are out there doing innovative work, and we need to work as a community to share those practices. So I really think we're going to have an interesting conversation today with Carol and Sanjeev, leading discussions as we move into the agenda. The other thing I want to note is the work that I do here at RAND spans a lot of different spaces, and there are a whole cadre of researchers here at RAND with an array of skill sets, knowledge, and engagement with different community stakeholders. And we have really welcomed the opportunity to partner with organizations such as yours sitting around the table as well as others to try to improve the quality of care delivered to patients in America. My own particular area of focus has been around trying to understand care redesign, which is really at the heart of today's discussion, but also the use of incentives, both financial and non-financial, to try to drive behavior of clinicians and other frontline healthcare personnel to do the things we want them to do. And when I say non-financial, that can be sharing information back so that people understand how well they're performing and kind of where they should be, to other kinds of things that are now being embedded inside of electronic health records to try to nudge behavior in the places we want behavior to be taking place. So I've had the pleasure over the past 8 or 10 months I'm running a very large study that's funded by the Agency for Healthcare Research and Quality, where we are studying health systems in 4 states in great detail, but also looking at health system performance more generally across the country, trying to understand what characterizes organizations that get to high performance and what kinds of actions are they taking to get there. And as one piece of that, we are looking at how they are, the extent to which they're using and what these things look like that they're doing to try to nudge behavior in the direction that they want. Because we've certainly heard over the past decade that, just throwing more money in front of people doesn't always, accomplish the goal, and it potentially undermines intrinsic motivation and so on. So I think we're getting a bit more sophisticated in the design of systems to facilitate and support providers to do the right thing, a la the RightCare initiative, right? With that, I want to turn it over to Hattie, who will lay out for you the rest of the agenda. But I hope to have the opportunity at one of the subsequent meetings to come back and share with you what we're learning from this larger healthcare system study. I know Chloe Bird, who I think many of you know, she is trying to partner with us on that system to try to use national data to try to understand disparities in cardiovascular care, leveraging some of the data that I have in my data core. So we've submitted a funding application, or I should say she has, but if that's successful, hopefully in the future we'll be able to come back and share some of that work with you. So, thank you.
It's great to have Cheryl Danberg and Margaret Maglione with us from RAND today. Alan Fremont and Chloe Bird could not be here, but I want you to know that our results from our first collaborative community were analyzed, and the data was supported for years by the RAND team. That enabled faster improvement in San Diego than our other collaboratives. So adding the RAND Je ne sais quoi with their substantial research background and ability to understand and organize data in ways that motivate health systems to improve is an essential ingredient that we'd like to add for LA. And we are actively seeking funding to be able to add that rigorous infrastructure piece that RAND may be able to help provide. So we are so grateful for their partnership with us since 2007 in constructing the RightCare initiative and guiding the way on what is most important. So when we So although the researchers change over time on the RAND project, they are consistently high quality, critically important partners in this endeavor to rapidly reduce preventable heart attacks, strokes, diabetic complications, and improve the management of heart failure and outcomes for patients. So in San Diego, the first community that we started with a grant that was written by Dr. Alan Fremont, MD, PhD, RAND, we showed that in the first 4 years, we reduced heart attack hospitalizations by 24%, and in an econometric difference in difference analysis, that was shown to be 16 points greater than the state as a whole. So this activity of coming together is essential for the outcomes of your patients, our community, and as the medical directors get to know each other, and they change depending on our meeting location, I have to say, because LA is almost as big as it's as big as many countries. I want you to, come early, stay late, get to know each other, because a lot of those conversations that happen before and after university best practices spark innovations that drive down the death and disability from these very preventable and manageable conditions. We know how to do this, and we have the data to show that when we make an effort, not only do we get the cholesterol controlled, the hemoglobin A1C controlled, the blood pressure controlled, through some fairly straightforward interventions. Hi, Pamela. That are on the Right Care triangle on the back of your agenda. One of the critical pieces we'll hear about next month is adding the pharmacist to the care team. I know we have a lot of pharmacists in the room with us today. Bless you for being here month after month, year after year, because we have seen such substantial data about how quickly that can make a difference for patients. So I want to just turn over the helm to our LA RightCare University of Best Practices, Dr. Carol Zaher, cardiologist who's worked at many of the finest institutions in the LA area, and who's joined our leadership team not only for our overall RightCare initiative work, but also for leadership on the heart failure Workgroup, which is, has enabled us to bring Dr. Sanjeev Bhavnani from Scripps to be with us today. So Carol Zaher is a senior medical director with HealthNet, and I will welcome her to the podium to give us the context for today. Carol, if you would please join me, and Megan will get your slides going there. Little do-si-do here. And while they get their slides together, I just want to say that the heart failure work group went down to visit the Scripps Innovation Heart Failure Clinic last month, and we're very impressed by meeting Dr. Sanjeev Bhavnani's team and learning about some of the innovative practices that have enabled them to reduce their readmissions rate to somewhere between 7 to 9%, which is 20 points lower than LA County generally. Thank you for making the trip up today to share. Everybody's not willing to share. That's been the biggest surprise to me, is that sometimes I'll invite a high performer to come share how they did it. It's like, why would I do that? This is our competitive advantage. So in this room, our rule is we compete against disease, not each other. So thank you for being part of it.
Well said, Hattie, thank you. As Hattie mentioned, we have a relatively new heart failure work group at the Right Care Initiative. And over the last several weeks, we've been discussing how we could potentially incorporate heart failure into our efforts here, and why that would be important. And as Hattie mentioned, it started to stem a little bit from this differential in the 30-day readmission rate for heart failure. And especially that LA, as with other measures in the Right Care Initiative, we seem to be a little behind our friends and colleagues in the northern and southern part of the state. So we should be a little more competitive in sharing and try to improve those statistics. So we're in the process of trying to define what the role for the Right Care Initiative would be with respect to heart failure. So what I'd like to do is give just a little overview of heart failure for those of you in the room. This is the more soporific part of the afternoon. Dr. Bhavnani will really spice it up a little bit with his talk, I can assure you. So if you fall asleep at mine, be ready to get some caffeine and pump yourself up. No pun intended there for heart failure. So I wanted to read to you, there's a 2017 American College of Cardiology expert consensus pathway for optimization of heart failure treatment. That wasn't the whole title, that was just part of it. But I want to read this to you, just a little excerpt from it. It says the care of the patients with heart failure is more involved than ever. Current care for the patient with heart failure with reduced ejection fraction includes no fewer than 7 evidence-based medications, 3 evidence-based device strategies, and a number of recommended processes of care. The opportunity to change the natural history of heart failure with reduced ejection fraction has never been better, but with more choices comes greater complexity. This necessitates careful guidance to clinicians, emphasis on best principles for initiating and titrating guideline-directed medical therapy for heart failure, and advice on managing the overall complexity of the condition. So that's, I think, somewhat of an oversimplification of where we are, but I think it pretty much states some of the issues we have. As medicine as a whole is getting more complex, my own feeling is we need to try to find ways to make it simpler, and I'll use that in quotes, so that we can really enact the change that will really be productive in improving outcomes in the future. That's my editorial comment. Okay, so I don't have any disclosures. My objectives are to really just sort of summarize for you some of the clinical and economic issues with the importance of heart failure on the system as a whole, provide a very high-level overview for some evidence-based guideline recommendations, and then try to further enhance why I think the RightCare initiative is a good place for heart failure to take a role alongside our other initiatives. So, just to look at an overview of my presentation, I'm going to very briefly discuss the different types of heart failure. This is, again, a high-level view. I'm not going to get really deep in the mud here, just to sort of give a sense of what we're talking about. Provide some statistics for the United States as a whole, and for the state of California. Talk about the economic and clinical burden of disease. Some of the disease management efforts that we've had in the past and where we've come from, and where, again, I think Dr. Bhavnani's talk will take us, and then talk about the role for the RightCare initiative. So, we all like alphabet soup in medicine. So we have basically 2.5 or 3 types of heart failure that we've talked about. In the old days, when we talked about heart failure, it was mostly systolic dysfunction we were talking about, and then some other entities came into being. So HFrEF, which is heart failure with reduced ejection fraction, is that typical heart failure that we've all known. Poor pump, low cardiac output state. So that's HFrEF. I'm not kidding, right? Then we have HFpEF, which is HFpEF, which is heart failure with preserved ejection fraction. So there are some patients who their measure of ejection fraction is normal, but they have symptoms and signs consistent with heart failure. And this may be an element of diastolic dysfunction and other things going on, but they're a little different than the HFrEF. And then even new to me was, I don't even know how to pronounce it, heart failure with improved ejection fraction. So somebody started out with a poor ejection fraction and then improved along the lines. So what's the big deal other than, HFpEF, HFrEF, all of this? Well, the underlying pathology might be a little different. The outcomes could be a little different. Some suggest that HFpEF and HFrEF are somewhat similar in outcomes. You would think if you had a preserved ejection fraction, perhaps you should do a little better. And then is treatment different? We know a lot about the treatment for heart failure with reduced ejection fraction. There aren't a lot of studies, clinical trials showing that what we should really be doing, say, for the HFpEF, the preserved ejection fraction. So I'm only presenting that to say that some of what we've done in the past and some of the evidence-based guidelines and treatments are more attuned, I'd say, to the reduced ejection fraction group. So just to keep that in mind. This is, so we're going to talk about some statistics here. This is the American Heart Association has an update for stroke and heart disease that they come out with. And I find it somewhat useful to look at burdens of disease and statistics for various heart disease and stroke entities. And there is a section on cardiomyopathy and heart failure. So for those of you who don't know this, I find this very useful, although it's a little, it's not hot off the press statistics, it might be several years back, but it's very helpful to look at the trends. Now, I will tell you though, that if you wanted to print it out, it's a mere 493 pages, so you might want to just copy the section that you'd like, but it is a nice entity. So some high-level statistics. So NHLBI study suggested that there are approximately 1 million new heart failure cases annually. So an incidence of about 1 million, somewhere probably between 750,000 and 1 million. That's a lot of patients. The prevalence of the disease, a little maybe hard to totally calculate because of these other entities that I talked about, what really is the heart failure that we're looking at. But about 6.5 million American adults had heart failure in 2014, and with only 5.7 million in 2009 to 2012. So there's been an increase in the prevalence of disease, and it's projected that it'll increase 46% by 2030 with more than 8 million people with heart failure. So why is that? Well, probably the increasing incidence. People are living longer, they're getting older, and as you'll see, heart failure is a disease of increasing age. And we have improved survival somewhat. So it's a problem that certainly will be around for a while. You see on the right, there are some disparities in the incidence of disease with respect to ethnicities. You can see the 30-day, 1-year, 5-year fatality rates up to 42%. When I was training, we used to say that 5-year survival for heart failure was just as bad as some cancers at the time, and a lot of cancers are now doing even better. So we still have room to improve there, although we have made improvements in survival. And the most common risk factors for heart failure are CAD, hypertension, diabetes, obesity, and smoking, which, as we know, are some of the issues that we're dealing with in our other right care initiatives for preventing heart attacks and stroke. So there's some common ground there. Burden of disease, discharges from hospitals, 1 million and 900,000 from 10 years from 2004 to 2014. 2 million, almost 2.5 million physician office visits, 500,000 ED visits. And as you see on the right, there's a substantial number of heart patients that are hospitalized at least more than one time in a year. So it's not only a clinical burden, it's an economic burden to the system, and it obviously has a social impact as well. Cost, it's not cheap. Roughly, again, in a study for 2012, looking at the value in 2010 dollars, almost $31 billion, most of which is direct medical cost, and most of those were related to hospital costs. By 2030, it's projected that it'll be a $70 billion entity. For California, it was a little hard for me to find some California numbers, but again, they're very similar, at least in trend, to the US statistics. You can see here that from the age group 65 to 74, it's about 4.7%, but as you get over 85, you've got over 10% prevalence of heart failure in the population. Again, the hospitalization rates have come down somewhat in California over the last decade, probably somewhat related to improved care and also the issue of seeing patients in an outpatient setting, especially the observation status, which is not really a hospitalization, but more of an outpatient, quote, admission. So the trend in hospitalization is looking good. The mortality, again, you can see there from 2000 to 2006, somewhat going up, and then starting to come down a little bit. I'm not sure the 2014 if that's really an uptrend, or hopefully not, but it looks like, again, a condition where we could probably do a little better. So I wanted to just, again, briefly take us back to, well, okay, so we're talking about what can we do about this? And I wanted to revisit the disease management efforts that we've had for heart failure. And if I take you back to when I started in disease management at the last century, actually, Okay, now let's do the math here. I'm not talking about the 1800s. I wasn't there when foxglove and bloodletting were the main treatments. We're talking about the 1900s. So in, I think the ACE inhibitors, the first one came around 75, the studies, and in the early 80s. Anybody remember what that drug was, that first ACE inhibitor? The old captopril, very good. So in the mid-80s, it did get an indication, in addition for treating hypertension, for treating heart failure. And then it led to a series of ACE inhibitors coming out. And prior to that, most patients were treated with DIG and diuretics predominantly, and tried to salt restrict their diets. So as the treatments for heart failure started to evolve, especially when ACE inhibitors suggested there was a quality of life and a potential mortality benefit, disease management took off at about the same time. Some disease management efforts, and one of the main disease entities that was popular for disease management back in the early 90s, I'd say, was heart failure. And then HEDIS came out with measurements for quality indicators, probably somewhere in the 90s, for trying to determine how we were doing as health plans and health systems, and measuring LVEF actually being measured in patients and the use of ACE inhibitors. And so the creation of disease management, case management programs to integrate care and try to really improve patient diagnosis and appropriate treatment, and then the longevity of that treatment started to take on more of an effort in healthcare. I mentioned here the observation unit. Again, one of the first CMS, I think it was an APC code for appropriate care or use of the observation unit was with heart failure. And so that probably started somewhere early 2000, maybe 2005. We developed heart failure specialists, heart failure clinics. We incorporated pharmacy in helping to have patients adhere to drugs. We ended up with scales being sent out to patients' homes so they could monitor their weight, telemedicine, some approach. So, and then ultimately trying to get to a real team-based approach, including a lot of providers. So we tried to make efforts at attempting to manage patients with heart failure better so that we could really improve the outcomes. But we're still not where we could be, and that's where I think some innovation and we have now more complex ways to treat patients. So it's becoming a little more complex that way, as I mentioned with that consensus statement. And yet we have to be a little more innovative into, well, how are we going to do this? How are we going to use all these different approaches to really individualize, optimize patient care? I wanted to speak very briefly about Get With The Guidelines. This is American Heart Association Collaborative Quality Program. Get With The Guidelines has several different entities, but there is a Get With The Guidelines for heart failure that I'll show you in a moment. The goal is to basically improve adherence to the evidence-based care for patients. It's voluntary, it's observational, these are for hospitalized patients for heart failure. It's a data registry, patient management tool that's part of it. There's some decision support, and there's some benchmarking, and some of the facilities decide to report their statistics, and there's some rewards for those who meet certain standards. This is an example of the summary. This is about a 7-page summary that you can get online for seeing what guidelines, Get With The Guidelines for heart failure is. But as you can see here, there are several components to it. One is achievement measures, one is quality measures, and then there are some that are just reporting measures. That as long as they're gathering all this data, they're getting information on several fronts. But I can read that without my other glasses. Let me pull it off. You can see that for some of the achievement measures, you have the ACE-ARB and the ARNI, medicines at discharge. You have the, measurement of LV function, which we talked about before. Post-discharge follow-up. That's really key for a lot of these patients, and especially as we talk about the 30-day readmission rate. it's essential to really get patients plugged in pretty closely after they're discharged, so they get appropriate follow-up and management of their condition and their adherence to medicine, et cetera. And then you have a bunch of quality measures which relate to the different types of medications, some device therapies, as we've talked about earlier, and then some of the typical influenza, pneumococcal vaccine, and then follow-up. So, and I won't go over the other pages, but there's a whole lot of reporting measures that they're looking for as well. So this is an effort to try to help integrate the care, make sure we can measure what we're